Warm welcome to London Central Local Practice Forum. We try and bring some interesting subjects, some useful subjects, some practical subjects for you to listen to. And each occasion, we try and make it accredited for your CPD. You will see that some useful information is already on the table, which will help you to complete and write up your CPD. This evening, I'll just go through with the program you probably already have seen. I hope you've already had something to eat, something to drink. Psoriasis, that's the part where we're starting. This is not mine, so that's why I'm not very good using it. So we've got two very able nurses who will take us through to different sections. So you can see psoriasis and medicine optimization is our first presentation. And then we have got an interesting DVD. DVD, which is, I think, maximum 7 minutes, 4 to 7 minutes. And then we're going to do a case study done by Anna. The first one, Paula will be doing this one, and Anna is going to do case studies, and then we're going to have a workshop, actually, hands-on, to see how the products are there and how we can use. And then in the end, if we get more time, we have allowed 15 minutes for that. But if we finish this earlier, we can, sort of go on for another extra 5 minutes or so, if the need be, for question and answer, evaluation. And we expect to finish by 9 o'clock. Some housekeeping points. I'll ask Deputy Lead.
Thank you, Zafar.
Take it from here.
It's always a difficult one, this one, isn't it? We always give feedback forms. If you get feedbacks, we'll give you your certificate of attendance, which you can file somewhere. So when you finish, give us a feedback form, and we'll give you a certificate of attendance. Fire escapes. I said there is no fire alarm plan here for training. So if you do hear a fire alarm, just run out. Go out from here, straight out, and get out onto the main road, or go out into the balcony. That's what I've been told. Toilets are down in the first floor. Apart from that, am I starting with the introduction straight away? There's nothing else. I hope you all enjoyed. And what's the speaker?
Yes, the first presentation is by Paula. Christine will introduce Paula. Christine, sorry, are you going to?
I was going. Yeah. Change your plan.
All right.
The deputies get small jobs. Well, it's a great pleasure for me to introduce. Is this thing working? Oh, this is after this game. Anyway, it's a great pleasure to introduce Paula Oliver, who's a nurse prescriber. She's going to talk on psoriasis and medicines optimization. Paula is a consultant dermatology nurse, and she's got a clinical nurse specialty in dermatology outpatient departments. She's got a whole range of things that she does, but quite interesting thing is that she's got a weekly honorary contract at Brighton and Sussex University Hospital, and she's practicing clinical practice there. She's currently member of the British Dermatology Nursing Group, and she's published various papers in dermatology from University of Brighton. Please join me to welcome Paula.
Thank you very much.
I'll just pop my presentation up.
Hello, it is also my honour to introduce Sister Anna Bianconi-Moore. Anna has been a dermatological nurse for over 20 years. She has been a senior sister and clinical nurse specialist in dermatology in Jersey. She has held various important posts, has led many important nurse initiatives, including light therapy, wound care clinics, minor surgery clinics, and skincare cancer, just to name a few. Currently, she maintains a clinical role on an honorary contract basis with the dermatology team at West Suffolk NHS Foundation Trust. So please give Anna a very warm welcome as well.
Thank you.
Right, we thought that we introduce both the speakers now, both the presenters now, so that you need to remember that Anna is coming second, Paula is coming now, and then there is a bit where both, it's a difficult one, so both will join the forces and they both will give the presentation. So there are two presenters, two very able nurses. Thank you.
Lovely. Thank you very much. Thank you for a very warm welcome, and it's our pleasure to be back again this evening. Recognise some of the faces that Anna and I were both here in September, and we did an acne evening for you. So thank you very much for having us back again. So many of you have turned out tonight. Really appreciate that. We want to make it a very interactive evening for you tonight. You've all had long days, I'm sure, and really you'd probably much rather have gone home and watched a bit of television, but you're passionate about what you do. You're here tonight, so we really want to do the best for you that we can. And both Anna and I have worked together for over 20 years in one way or another, and we're very passionate about dermatology. And we just wanted to congratulate Safar on his amazing star role on the One Show the other night. It was quite moving, and I was really excited to see you on television. It was wonderful. So we both thought so, didn't we? Yeah. So we're going to start off with psoriasis. I'm going to start off with a brief overview of the disease area. We've got, as Safar said, we've got a small DVD clip, which is a role play situation between a patient and a patient with psoriasis, a nurse prescriber, and a patient suffering with psoriasis. So it's really about a consultation, and bearing in mind GPs will have about 7 minutes only to do a consultation with a patient in primary care. Now, we appreciate your roles are hugely important moving on. All the time we're hearing more and more about the important role of pharmacy and pharmacists and practice support pharmacists to actually support the NHS, because we are really struggling all together. And I get an email from my GP surgery every month, and I had an email today saying, please think about using the pharmacy before you come to the GP. So you're really being advertised out there, and your expertise is very, very valued, because I think the same as nurses, patients will come to you and ask you. They may not ask their GP, but they feel that they can ask you questions and possibly confide in you with some of their problems that they have. And skin problem is a massive, massive area. I think there's about 2,500 skin diagnoses that it exists. So it's a huge area, and we can't know all about everything, but there's an awful lot we can do to help our patients and support them with their therapies. And hopefully we're much more likely to get adherence if we can support and educate them. So I think that's really where we're coming from tonight, isn't it, Anna? So do just ask questions as we go along. We really want to make it quite interactive and relaxed, mainly. Okay, so I've had a wonderful introduction. I'm employed by Galderma, as Anna is, as we're both nurse educators. So we spend a lot of time in primary care with GPs and nurses. We love pharmacists and we love podiatrists. They're such a lovely group, and they turn up in good numbers and are very keen to learn. So that's fantastic. I do have my honorary contract at Brighton and Sussex University. I work out of Haywards Heath, the hospital there, and run a weekly non-melanoma skin cancer clinic in that service. So we'll get going, and Anna's going to keep me to time. Very much so, keep me to time, I know. So, how many patients do you have coming into the pharmacy that really need your advice on their psoriasis? No one? Yeah, come on. You must have some patients that come and ask you questions about psoriasis. Yeah, they do. You saw one last week. Yeah, it's a big problem. So if you can imagine, these are some of the clinical pictures that we see when we see our patients. You know, it can be very, very mild, it can be moderate, it can be severe, and it can affect all parts of the body that we'll have a look as we go along. So really the learning outcomes of this session is to just give a very brief overview of the underlying pathophysiology, looking at some of the trigger factors, because there's some of the things that you can think about when you're with your patients. Look at the different subtypes, the different ways psoriasis can present itself, because we see it on the scalp, we see it in the nails, we see it on the trunk, we see it in the inverse, so the flexural areas of the body, and it can look very different there. And our treatments are going to vary depending on where on the body the patient has that disease. There's a big thing about comorbidities now that are associated with psoriasis. And there's a wonderful, if any of you want a bit of bedtime reading, 476-page nice document that can advise you on how to care for your patients with psoriasis. But the good news is that Anna and I have printed off 2 algorithms out of here that may be helpful to you, rather than you having to sieve through the whole of the document. So they're down at the back. And then really about when to refer on, but there is an awful lot you can do in pharmacy to help these patients. So it's a very complicated chronic inflammatory condition, non-contagious and reoccurring, and predominantly affects the skin and joints. But as I say, we are seeing associated comorbidities, which we'll talk about a little bit as we go along. Psoriasis was first described in 1808, just for your interest, by a guy called Robert Willen, who was a physician who was the first, he first discovered the speciality of dermatology, and there was an issue between, was it psoriasis or was it leprosy? So he first termed the coin, or phrase rather, psoriasis. And psora, as in the Greek word, is itch. Because quite often people think psoriasis doesn't itch, but actually it does, doesn't it, Anna? It does. So it affects 1 to 3% of the UK population. I was at a conference a couple of weeks ago, an international conference, and one of the lead clinicians from Manchester, Professor Griffiths, was saying that over the last 30 years we're seeing a real trend. More and more people are being diagnosed with psoriasis. So whether that's associated with comorbidities, we don't know, but more and more people are presenting with this disease. Historically we've said it affects males and females equally, but the new emerging evidence is to see it has, there are more males that are presenting than females. It can occur in any age, and we see children in clinic, and we see older patients too. If they've got that genetic tendency, it can occur at any time in one's life. But there are 2 peak times when we see it, late teens to early 30s, and then later on in life as well. Most common in white people, the highest prevalence is Northern Europe. So the higher we go up above the equator, the more likely there is to be patients with psoriasis. And as we've mentioned, there are several clinical variants, but plaque psoriasis that you will recognise from some of those slides is the most common. So we understand about the skin turnover. So in normal skin, our keratocytes from the basal cell layer in the epidermis mature over 21 to 28 days. But with patients with psoriasis, there's a rapid cell turnover, and that's every 4 and 5 days. So you get these heaped up scales on the top of the stratum corneum shedding off abnormally. So most of our treatments down the end there are designed to inhibit that cell turnover. So we're understanding a lot more about psoriasis, and I'm not going to go into great detail. We used to always say, oh, it's a genetic condition, it runs in families. And that's true, but we're understanding a lot more about the immune system, and a lot of the expensive biologic therapies now are targeting in that way. So we are we have got more treatments coming on board for these patients. 10% of the population inherit one or more of the genes that create this predisposition to psoriasis. So, you know, it can occur at any time in our life. And we've talked about the 2 to 3% of the population. And they must have that combination of the genes that cause psoriasis and then be exposed to possibly a trigger. And we look at the trigger factors. Stress, and that's, well, I mean, in a lot of the literature, we read that a lot about stress and psoriasis. And our patients that come to us in clinic will often be able to link a flare-up of their disease to a significant event, maybe a death, bereavement, or something significant in their lives. Injury to the skin. So psoriasis can occur on the skin that's become traumatised, and we call that the Koebner phenomenon. And there are a list of medications that you'll be more familiar than I, but there are also medications that can trigger psoriasis for some patients. Infections, another one, particularly the streptococcal infection, and that's often associated with guttate psoriasis, which I'm sure you may have seen in your experience, in your roles. You know, patients often come, they've had a throat infection or upper respiratory throat infection, they felt unwell, and then 4 or 5 weeks after they've had this period of being poorly, they come out in this rash with these sort of raindrop appearance type plaques on the skin. And with hormonal changes as well. Again, there are times in one's life where it can trigger psoriasis. So diagnosis is usually an easier diagnosis than some of the other dermatological diseases that we see. With eczema, you often think of, you know, the rash in the flexural areas, sort of here, behind the knees. So the pattern is quite different. But in psoriasis, it's often the external surfaces of the skin, so the elbows, we see it on the nails, they get pitting of the nails. They may well have psoriatic arthritis as well. They get these red, well-defined plaques, almost you can draw a line round it. You get the silvery scale, mostly apart from the flexural areas where the skin looks very smooth and with erythema, and that often gets misdiagnosed by our general practitioner colleagues as intertrigo or what's the other thing I'm thinking of?
Fungal infection.
Thank you, fungal infection. So it can look very, very similar in the flexural areas, and it isn't always easily recognised. It's often symmetrical, so you often see it on both knees and both elbows. It can be mild, it can be widespread. You can sometimes, if you scratch the skin on a plaque of psoriasis, get little bleeding points. This is termed as the Auschwitz sign. And lesions on lower legs may be less typical. And I think Anna's got a case study with a patient with plaque psoriasis on the lower limbs. Assessment.
Excuse me.
Yeah.
Where is the normal rheumatic psoriasis? Which joints is it normally?
It can be any of the joints, and there's a score called the PEST score that Anna's going to talk about as well. A simple, examining all the joints, and the patients would just document anywhere that they've got joint pain, and then they would be referred to a rheumatologist. We tend not to see them really, do we, Anna, in clinic?
I see some.
You do?
Yes.
Yeah. So we've got the score.
So is there a relation between rheumatism and psoriasis? There's an external condition, rheumatic factors. So is there any relation
I
there?
think it's more internal rather than external.
Okay.
It's all internally driven.
No, thank you.
But the score we've
Sorry,
got.
Paula, but
Yeah.
just one quick one.
Mm.
I think you said that GPs often mistake or sort of.
Sorry, we can't hear this at the back.
Yeah.
Sorry. Sorry.
GP. Yeah, I think perhaps if you can sort of.
Yeah,
repeat
relay
the
it.
question.
Yes, I will. I'll relay it.
Repeat the question. Yes. The main difference between the fungal infection, because that has got defined
Yeah.
Outer marking,
Yeah.
and this one. What's the main difference? How do you
Right.
distinguish?
The question was about the differential diagnosis between fungal infection in the flexural areas and psoriasis. I mean, if you see fungal infection on the body, you do often get that accentuated border with clearance in the middle. But again, with psoriasis in the flexural areas, it can just look like very red and inflamed. So it looks slightly different than it would do as an fungal infection on the trunk or limbs.
Right.
So, you know, when we see...
More demarcated
Yeah.
in psoriasis.
Yeah, so you would still get that well demarcated area, but it's smooth and you don't see the silvery scale. So it could be the groins, the axilla, the umbilicus, under the breasts, and they're places that you often see fungal infection or intertrigo on patients. Does that answer that one?
Yep.
Okay, lovely. So you know, we would take a typical history basically from the patient, their presenting condition, taking their medical history and the family history, because as I say, it does tend to run in families. We do see that genetic link. Important obviously to think about their previous treatments, because we do know, and Anna's going to touch on some statistics, but patients with skin disease, there is very poor adherence to topical therapies. For various reasons, they don't want to use them. It may be, as you will see later on, the smell, the feel of the product, the greasiness of the product. So we really struggle to get patients to actually adhere to their therapies. So it's important to engage with them to try and establish why they've stopped using those products. And that's something I think in terms of pharmacist and a nurse, we can do quite well to try and unravel what the issue is and why they've not used their products. There are lots of different scores in dermatology that we use about quality of life and also the severity of psoriasis. So there's a PASI score that NICE recommends should be done for all patients in primary care that's seen by a GP. And it's not ever going, it's a huge task for them to do. You have to be trained to do PASI. PASI stands for Psoriasis Area Severity Index. So every patient that goes into secondary care to have their psoriasis assessed will have this measured. So how big is the plaque, how thick is the plaque, how much scale have they got, how much body surface is this covering. They then have a score, and with that score, that's the sort of score that can help dermatologists decide on whether patients should go on more toxic systemic therapies in the future. But with NICE recommendations, I don't see this ever is going to happen in primary care, because it would take the GPs or nurses a long time to do, and quite often they haven't got the skills and expertise in that area. Is that true, isn't it, Anna?
Yeah, very true.
So we also think about how the patient's feeling. You know, people assume it's an infection, they're going to catch it. They don't want to go in a swimming pool because people are looking at their body with the plaques. They don't want to go and stay in a hotel because when they wake up in the morning, the bed is full of skin scale. So it has a huge impact on their quality of life, and we do spend a lot of time trying to establish exactly how they're feeling. And another big area in dermatology at the moment is psychodermatology, really ensuring that healthcare professionals establish how patients are feeling. There is this PES score, which Anna's going to touch on, for psoriatic arthritis, again, which NICE is suggesting should be done routinely, and also to think about comorbidities and other health problems. So it does have a huge impact on the quality of life, psychological, social. They can get chronic itch, the areas can bleed, they can get this scaling that can shed everywhere, and they can get quite dystrophic nails and onycholysis, lifting of the nails, and they're quite unsightly, and sometimes they're just difficult to function and touch things and pick up things and work. So it does have a huge impact, but unfortunately we haven't got an awful lot for our patients with nail psoriasis. Our treatments aren't fantastic. It's a very disfiguring skin disease, and obviously people have difficulties with relationships, securing employment, and it leads to poor self-esteem. And about a third of people with psoriasis do have major psychological distress, and reported suicides. That's well documented too. These are the comorbidities that are gradually being unravelled, and so these are things that dermatologists would be considering and thinking of. And these would be all the areas that we would be examining on the body, because these are all areas where we will commonly see psoriasis. So scalp, ears, elbows, nails we've mentioned, knees, etc., and toenails. So they're all areas of the body that we can see psoriasis in. This is the just the slide that gives you the guidelines, psoriasis guidelines. There's actually another huge volume as well which talks about phototherapy, so the light treatment that patients might have if they end up going into secondary care for treatment, or intermediate care indeed. There might be clinics, community clinics that deliver phototherapy as well. So if you're welcome to tap into that little book. Basically, this is the slide that would show the pathway of medications that would be used with psoriasis. So, generally these would be the primary care interventions. So, and emollients is at the top. And again, Anna's going to talk a little bit about emollients, because in NICE there's an assumption that every patient that's seen by a GP with psoriasis will be prescribed an emollient. And that's not always the case, sadly. So emollients are hugely important. So again, that's something else that as pharmacists you can really check that they're using a good emollient, whatever they're happy with. It could be something that they're buying over the counter, but that will help descale the actual plaques.
Does anyone use Dithranol nowadays?
We do still use Dithranol, not as much as we used to. I mean, Dithra cream, the different percentages of Dithra cream, but Anna and me grew up in the days where we used to admit patients, cover them with Dithranol, Lasser's paste, wrap them up in bandages, yeah, and
horrible thing.
Admit them into hospital because the psoriasis was so bad. But some patients are still admitted, but not so much now. So it's not as popular because patients don't like the smell and the mess, sadly.
Very dangerous. But
Yes, it has to be used appropriately. So we're going to talk about these treatments down the end with you after in the workshop. We've got sort of examples of most of these on our product workshop down the end. So if they're failing those treatments, then they would just naturally go up the ladder.
Cold tar preparations, are they still the mainstay?
Probably not the mainstay. Vitamin D and vitamin D analogues are probably the most popular topical treatment with corticosteroids as well. Some patients do like the taroid, things like Exorex. So there are tar treatments out there patients do still like, but that's the minority.
Yeah.
Shampoos, Capacel, tar shampoos are popular too. So, but generally for the body, patients are preferring a combination of vitamin D and steroids to actually improve the skin. And again, we'll talk a bit about that as well. Okay, and what NICE is suggesting about that. So I'm not going to go into the other going up the ladder, but basically it would be, phototherapy, then onto the systemic medication, and if you've failed all of those, then biologics may be considered, and that's very much a secondary care intervention with close monitoring, obviously because of the drugs. I'm going to flick through that one because Anna's going to talk about emollients, but really important to remember that, and a lot of patients haven't got an emollient if they've got psoriasis. So just some pictures of plaque psoriasis, typically patients that we would see. And this is taken from NICE, the NICE guidance, and again we've printed off this algorithm for you down the end there. But the main thing that NICE suggested in this document is that we should separate out the vitamin D analogue and the steroid. So actually using a combination product with combining vitamin D and steroid in the long term was not recommended. So this is their first line recommendation, that we would use a potent topical steroid once a day, and at the other end of the day we would use a vitamin D or a vitamin D analogue. Patients have been stuck on combination therapy, repeat prescription quite often, and obviously has led to steroid atrophy, and at worst abruptly stopping, a rebound, and then becoming critically ill with erythrodermic psoriasis. So we're trying to encourage patients. It's tricky because if they've got one combination product, it's much easier to use, you're much likely to get adherence, but actually separating them out is safer practice. So this is the algorithm taken from NICE.
Sorry, can I just ask you, do you think antihistamine tablets help?
I don't think so personally, no, and I don't see any dermatologist antihistamines, no, I don't think so.
When it's severely irritating.
No, I don't know that it's always hugely helpful in eczema even. I mean, there's things like hydroxyzine that's more effective, I think, but generally I think probably not. We'd probably try and increase their emollient regime and trying to get them to increase that rather than anything.
I meant antihistamine tablets, not
Yes, no, I don't think so. That's a good question though. Anything to try and help our patients. Scalp psoriasis, and we've got some demonstration down the end there of what patients need to do, and the key thing is they must descale. They've got thick psoriasis on the scalp, they need to descale, so they need to use an ointment, an emollient, coconut oil, and we've got some an example of Cocois or Sebco down the end, which is an amazing descaler. Anna and I will show you an example down the end when we do our workshop. But they need to descale it before they put any other active treatment on, otherwise it's just going to sit there. And patients haven't always been taught that. Scalp treatments, first line would be potent topical corticosteroids once a day for up to 4 weeks, and then review. Some clinicians might use very potent, so you might be up to sort of a very potent strength for the scalp. Thickened area, and it may well tolerate a thicker potency. And then obviously you can read through the recommendations there. Face, flexural genital psoriasis. Obviously we can't go in with potent steroids in these areas, more sensitive areas. So first line in terms of NICE guidance would be short-term, mild to moderate potency steroids once a day or twice a day for up to 2 weeks. And second line would be possibly calcineurin inhibitors, so Protopic and Elidel, but I don't think they're licensed. You tell me, they're not licensed for psoriasis, are they? No, but that's been recommended.
5 minutes over.
Okay, 5 minutes over, I've been told to speed up. Guttate psoriasis is something that you may see people coming off the street and say, I've not been well, I've had a throat infection, I explained earlier on, and I've come out with this widespread rash. It can look very similar to other viral rashes as well, but if that's the diagnosis, they do very well usually with phototherapy. They do well with tar ointment as well, if you can get them to use some tar, but mainly they do better with phototherapy, so some UVB into secondary care. So I think we've gone through that.
So sorry, this how soon after the
Usually
infection
about
you
four.
will see this? 'Cause
Usually
it's
about
quite infused.
usually about 4 to 6 weeks after they've had that sort of period of being unwell. They can just come out in this rash. They're usually very stressed. I think if you can imagine, if your body is covered, how difficult it is to put topical treatments on all those areas. So that's why generally they get referred in, don't they, Anna, for UVB, and they do very well, very quickly with UVB. But you are limited to refer patients in, I guess, and there's a waiting list. But yeah, they do they do sort of struggle with putting their treatments on. So emollients, again, first, it's really important. They can use vitamin D, but if it's covered all over, it's really difficult for patients to adhere to treatment, and then possibly refer for UVB. Or a nice holiday abroad on the NHS, they'll probably get better then. And then palmar pustular psoriasis, again, it's very common we see. You get this sort of, you can see these hands are very, very sore. You can see they've got sterile pustules there, it's not infected. Quite often by the time we see them patients, the GPs put them on antibiotics because they think they've got infection. It's not, it's just sterile pustules. There's a strong link to smoking with these patients, very common in the over 50s group. Quite tricky to treat really, quite unsightly, and again we can go through some of the treatments down the end that we'd use. And that's generalised pustular psoriasis. So this is rare, but it's a dermatological emergency. And we did have one lady at Worthing who abruptly stopped her steroids, topical steroids on the body, ended up with sort of a rebound of the steroid usage and ended up in ITU. So that is one of our emergencies that the dermatologists have to deal with. And these are all sheets of sterile pustules and they're very, very unwell patients. Need admitting.
Could I just check with this? How long was she put on the steroids?
She'd been on them months and months and months, yeah. Yeah, just repeat prescription, and then was abruptly stopped and then ended up in trouble. We do see it, don't we, Anna? Generalised pustule, and there's just general erythrodermic as well. Nail psoriasis, again, they get pitting of the nails, lifting of the nails, quite unsightly, but our treatments aren't fantastic for that. We used to use some of the Dermovate scalp application and use those as drops or to massage steroid into the nails, but it's not very effective. So that's nail psoriasis. This is our erythrodermic patient who's, you can see the skin there. They're very unwell, they come in, they're shivering, they need admitting, they need fluids, and they need usually intensive care. Very unwell patients, but sadly we don't see that many of them. So referring really, if there is diagnostic uncertainty, if there's whole body spread of the psoriasis that's flaring, anything that's not being controlled with topical therapy may need referring in to secondary care. If they've got acute guttate, they may need phototherapy, so they may need that referral in. We have had patients that have had so scarred or so psychologically disturbed by their nail psoriasis that they've ended up on biologics as well, and it's really because they've just been so stressed out by it. So I think, have you heard of that, Anna?
Yeah.
Yeah.
Yes.
And
they can't get employment, a lot of them.
Yeah.
They can't hold down jobs.
Because of their nails, they can't function with computers and things like that.
Or if they're people facing and have to do a lot of handshaking or interact, it can be hugely embarrassing.
And any type of psoriasis having a major impact on a person's general well-being warrants a referral in for an assessment really. So, you've got some references on the back there. The reference for the clinical guidelines here, but as I say, we've got the algorithms at the back for you to take. The BAD is a fantastic website. They do amazing patient information leaflets. And this is the Primary Care Dermatology Society. Their website's very useful in dermatology. And then that's just the Psoriasis Association, obviously, particularly about psoriasis. So I'm very briefly going to just put it's only 4 minutes, Anna, so will that be all right?
No, I don't mind.
I'm just going to put the DVD on. So this is just a role-play situation.
I'm not going to waste any time reinforcing any introductions because that's already been covered, and that's not working, Paula.
So we've got books tonight.
Bloody hell. We've got gremlins. There we are. Okay, so here we go. We know this is going to be psoriasis, so I'm not going to leave you guessing because the topic is psoriasis. Why is it not working? Sorry, go back. Okay, so this is actually, although it's not the actual image of the patient, but we had a real life scenario of this recently where we had a youngish male He was a long-distance lorry driver, and he developed psoriasis some 5 years after having a sore throat. His skin deteriorated over the previous 2 years. He does smoke, he was or is overweight, and he was finding it difficult to use his treatments because of his long working hours, because of what he does. So he would be between Europe and the UK. Because of his, we don't know whether it's because of psoriasis or because his marriage went bad, but either way, he lost his home and he basically lived in his cab. How did he bathe himself? How did he get to use his, keep himself clean? The answers were, in our case, he used baby wipes or body wipes to keep clean. And he subsequently developed erythrodermic psoriasis, probably triggered from an allergic reaction to the wipes. So we do have to be careful with these wipes that we encourage people to use. I'm just adding that in as something anecdotal, but really did happen. And he spent 3 weeks in intensive care while they sorted him out. So patients like this pose a huge challenge in terms of conventional topical treatments. And I guess because of the body surface coverage here, and you can see it's most of his lower legs, and in psoriasis you do get a symmetrical distribution. If his legs are affected like that, the chances are it's widely affected his sacral area, probably similar areas on his arms, so it's going to be fairly widespread. Now, patients like that, if the guidelines I think still say if you've got 20% body coverage, you should be referred into secondary care for phototherapy or other therapies. And I think this chap probably has at least 20%, if not more. So in terms of treatment, what would be the first thing, bearing in mind what Paul has just explained to you about topical treatments and the NICE guidelines, what do you think should be first line here?
Emollient?
Emollients, yeah. Good answer. What type of emollient? What sort of formulation? Shout up because... sorry? Ointment? Okay. I'm going to ask you, have you ever had to cover yourself in ointment, put your clothes on and go to work? It's horrible. But you're right, ointment is an option. However, bear in mind that these patients are already, in many cases, severely psychologically burdened, if you like. So ointments are not an aesthetic option for during the day. Ointment at night, certainly, and some other form of emollient during the day. You get more concordance like that, I think. Bear in mind also that you've got a lot of scale here that needs to be shifted, because if you put your topical steroid, your corticosteroid, regardless of potency, or your vitamin D analog on scale that's fairly adherent, you're not going to get penetration of the actual therapy that you want to be absorbed into the epidermis. So you have to descale first. So if there's one thing you learn about tonight regarding psoriasis, regardless of what form of psoriasis, you need to descale before you start the active treatment. All right?
Now, won't that cause bleeding when you descale?
No, because you're doing a chemical, well, you're doing an emollient descale, not using any harsh chemicals. The formulation that you should possibly be considering are your emollients that contain keratolytics. Now, what do I mean by that? Salicylic acid, urea, lactic acid. So on the table in the bottom left corner there are just a couple of samples of different brands that contain different humectants. That's another word for an active ingredient, is a humectant. So just have a look at the end of the evening, okay? But you'll get a better outcome or a quicker outcome if you descale first. The patient will respond more quickly to the prescribed therapies, and they'll become less disenchanted with you.
Does smoking cessation?
Yes, it will do, but that's a long process. But then getting a clearance rate in psoriasis is equally a long process. And in reality, when a patient starts topical treatments, it can take anything from 12 to 16 weeks to start to see an improvement. It's not something that happens overnight.
In that kind of state, does water exacerbate the contact with water in that kind of position?
Not really, no. Water can exacerbate eczema more than psoriasis. No.
Sorry.
You might have pointed the laptop.
Oh, it's the right one, aren't I? Yeah.
Yeah.
Is the battery going? Anyway,
Shall I
can you just
yeah,
advance it for
sorry.
me? Yeah, thank you.
I think we have got
So-
gremlins tonight.
So this is a sort of basic overview of how we deal with psoriasis, or the sort of the epidemiology or so. Paula's already covered this, so if you could move it on for me,
Yeah,
Paula.
surely.
I don't want to waste any more time on this. And again, you've seen this slide, but I'll just again, Paula's slide is slightly different. Hers says emollients at the top, and it should always be emollients at the top because of the descaling issues. But very much so, the topical therapies in the first step are really all the areas where you guys can focus and help. And MURs in particular are really, really beneficial for these client groups. Very often patients who have psoriasis and have had it for years are on the same old, and nobody's reviewed them for years. They get their repeats from their GPs and nobody questions it. And one of our colleagues did MURs in a CCG, and it was astounding how grateful the patients were that they finally had a review, because some of the treatments they'd been on were not working. And you do sometimes get a plateau in response, and we call that tachyphylaxis, and sometimes that can be soul destroying. And just in terms of long-term therapies, there is lots of evidence that are saying now that long-term therapy adherence is only between 40 and 50% of patients, and psoriasis patients fall in that group. And equally, short-term therapies, there's a slightly greater increase of adherence, that's 70 to 80%. But psoriasis, topical therapies, only 60 to 70% adherence. So you're getting 30 to 40% wastage. Now you equate that into pounds, shillings and pence, and that's a lot of money. And it's not only is it a lot of money for their serious medications such as their vitamin D analogues and so on, but it's also wasted money, and billions is wasted in inappropriate emollient prescribing, i.e. prescribing an emollient you think the patient should be using rather than the emollient the patient is willing to use. There's a big difference, okay? Severe psoriasis patients, less than 40% adherence. So that's a big gap in getting good outcomes. Okay, yes please. When we talked, we mentioned the PEST score. This is all it is, and anybody can download this. You can laminate it, you can get the patients to write on with one of those whiteboard removable eraser things, because then you can reuse it. And all it is 5 little questions that the patients complete, and then you score it. And it says if a total score of 3 or more out of the 5 is positive, that indicates a referral to dermatology, who will then cross-refer to rheumatology. And there is an increased incidence of psoriatic arthritis in mild psoriasis. So the people who come in with small plaques on their elbows and knees, don't assume that their psoriasis is so mild it doesn't need any attention, and they're maybe not bothered about the plaques. It's good to see if they can, if they have any symptoms. Going back briefly before we go to scalp psoriasis. Yeah, sorry.
Say that was downloaded from
I'll just do PEST score, Google it, and it'll take you to it. All right. And you'll probably find it in the BAD website as well, the British Association of Dermatologists website. Going back very briefly to that lovely document that anybody would love to have for bedtime reading, we figured out a quicker way to digest that document. And if you go into NICE guidelines for psoriasis, you'll find a small PDF file that says algorithms. That's where you need to go. And there are 7 algorithms for the management of psoriasis, and we've printed off 2 that we think are relevant to tonight. But I'll just read the first page of algorithm 1, or not the first page, but the first box. Algorithm 1 is how to assess people with psoriasis. Now, as pharmacists and discussing stuff with patients, you may well have to have a little consultation in a private area with a patient, but that qualifies for you as well then, because it says all settings. It doesn't say GPs, doesn't say hospitals, community settings, it's all settings. So for anybody who has interaction with patients with psoriasis, you have to establish disease severity, the impact of the disease on the psychological, physical and social well-being of the patient, and whether they have psoriatic arthritis, and the presence of comorbidities. So that is all our responsibilities, including mine. Now, where is my other thing? Oh Lordy, where's it gone? I've forgotten. Doesn't matter, come to me in a minute. My DLQI is at the back. There is a dermatology quality life indices, which I have a copy of at the back, which you're welcome to look at. And again, that is not an onerous thing to fill in, because you're not tied to a 7-minute consultation as our primary care colleagues are. You may just have a bit more time with your patients. And it is just an A4 document with 12 questions. Patient fills it in and you do the score. And then again, you're able to establish what impact their disease is having on them. And it's not rocket science. It doesn't take some, complicated algorithm to interpret it. Okay? So those are two things that can be done very easily. But do have a look at these. They're very useful and they can help you guide very quickly through the necessary steps to manage psoriasis. So scalp psoriasis, very common. What percentage of patients with scalp psoriasis, no, turn that question around. What percentage of patients with chronic plaque psoriasis present with scalp psoriasis, do you think, in this country? Anybody shout out a percentage for 90, okay. Any other? 50? 60? It really depends on the literature you read, but you're kind of in the middle there. It's roughly between 70 and 80%. So that's a high incidence of scalp psoriasis. Patients may not always realise they have scalp psoriasis. They may just think they have dandruff. So for some of the patients who don't understand about the disease process or know nothing about their condition, these patients may have that as well. You can have scalp psoriasis in isolation with no other body psoriasis, or it can be present with other elements of psoriasis. They shed very quickly, a lot of scale, very visible, so don't wear dark clothes. They wear light coloured clothing, you advise them to. And certainly some of our patients that we used to have for phototherapy, we would sometimes, if they asked us about hair advice and what to do with their hair, obviously it's a bit different slightly for females, because females aren't likely to want to have a number 2 haircut, whereas males may be more conducive to that. And it does help managing your scalp better if you have shorter hair, but obviously that's not the ideal world, is it? We have all sorts of different takes on hair. So heavily shedding, also extremely itchy, more itchy than body psoriasis. So with itch comes what? Yeah, you scratch, and then what happens? You pick, because depending on the amount of scale, bleeding, sometimes a little bit of infection, but it's more likely to be excoriation. So some of our products that we have for scalp psoriasis have a fairly high alcohol content. So if you know your patient has a very itchy scalp and you can see they scratch while they're talking to you, you possibly might need to rethink about what products you would best guide them towards, all right? Because you don't want the ones with a high alcohol content, because what happens as soon as you put it on? Stings. It's like having 1,000 paper cuts in your scalp. It stings. So again, the issue of concordance might come up, okay? If we can move on.
Yeah, surely.
Have I got enough time to finish this one?
Yeah, it's not too...
Okay, extremely itchy, as I said. Depending on the degree of scaling, and in some patients it's really, really, really thick, and it can break hair. So you will get patches where the hair has been broken off. So when the scale comes off, then there's patches, not quite alopecia, but not far off it. As I said, it has a huge psychological burden. Remember to descale first. Again, really, really important. there aren't that many products out there for scalp descaling. Sebco and Unco's Co are the two that we think of. The BNF says leave it on for an hour, but most dermatology departments I know of ask their patients to leave it on overnight, providing there isn't an irritation triggered. Obviously, if there's irritation, you have to wash it off. But usually overnight, under occlusion. So go to bed with a beanie hat or something. Don't go to bed with a shower cap. Have any of you had to go to bed with anything that makes a crinkly noise in your ear? Not pleasant, and you're not going to sleep very well. But it is an option, but shower caps tend to come off in bed. You can wrap the head in cling film, but equally not very nice. So real challenges for psoriatic patients. Topical applications do include potent or very potent topical steroids, which is contrary to what you would apply to the body. So the scalp doesn't show the same steroid damage that the general body skin does. You don't get the telangiectasia, you don't get the thinning. And also most of the potent topical steroids that you would be applying to the scalp, you wouldn't be doing it long term. You might do it intensively for maybe 4 to 6 weeks, then you would start to tail it off because you should have started to see an improvement. Remember to discuss the treatment options with your patient. A good thing to do is to ask patients to bring in what they've got at home. That's a real eye-opener. You can see on the screen, on your computer screens, what they've been prescribed from your checking on the previous prescriptions, but that doesn't tell you anything really. It doesn't tell you what their behaviour is and how much they're actually using. So if you are in the sort of business of doing MURs, it should be a sort of a blanket agreement that the patient brings everything they've got for their psoriasis into the pharmacy and discuss why it hasn't been used or which works best and why and so on. A bit labour intensive, but a cost saving in the end. There are a wide range of routes and wide range of treatments and topical applications, so you can remember your formulations. Choose a formulation that's best going to suit the patient's lifestyle. All right? I don't know if there's anything left.
I think that's it, Anna, but yes, well, I think
That's
in
it.
the absence of me getting this thing going, we're waiting to the
We'll just try and see if we can get this DVD,
Sorry.
because we were given a challenge.
You can always talk afterwards. Can you please come back here?
Yeah. Here's some stuff, fresh bits. You know what I mean, though?
Well, I really want to say a big thank you for all of you to give your precious time to come here. Hope you have found the presentation and the talk from these very able, lovely ladies useful and practical. Hopefully we'll be able to apply those in our practice. I'd just like you to know that this event today, this meeting, was fully sponsored both for the food and the venue by Carl Derma. So a big thank you to Carl Derma. Hopefully they will carry on sponsoring us in future too. We will again try and bring some interesting topics. I had some feedbacks for some topics for future reference. One of them is depression, so hopefully we'll bring those. And in our usual way, can we say a very big thank you to two ladies who've been an excellent presenter.
That's right.
Thank you very much. Safe journey home. Please carry on talking to the ladies.
It's a bit late now.